So I think we can go ahead and get started. And I see that Holly Shaw has joined. Holly, thank you so much. Holly is going to open up the panel today with a few words and then turn it over to Dino, who will be facilitating the webinar today. Thank you so much, Holly.
Thank you, Dr. Hoffman. As she said, I'm Dr. Holly Shaw, and I'm very pleased to greet and welcome you to the United Nations Commission on the Status of Women in its 70th year, where I represent the International Council of Nurses and the Katharine Densford Center for International Nursing Leadership at the University of Minnesota, where I'm the director of the Center for Nursing Engagement and Leadership at the United Nations. The CSW, Commission on the Status of Women, is a yearly mandated event by the United Nations that holds multilateral governmental sessions for nearly 2 weeks this year from March 9th to the 20th to discuss girls' and women's progress in achieving gender parity, equity, and access to all of life's advantages. In addition to the governmental sessions, which involve every country in the United Nations, as well as some civil society, there are government-sponsored side events and civil society parallel events as this one. We so far have around 8,000 people attending 750 parallel events this year, and we expect that to continue on. During these events, there's an opportunity for civil society advocates and activists to network together and to share their knowledge with the focus of listening to grassroots voices that might not have another opportunity to collaborate with global partners. I'm honored this morning to introduce a nurse-led interdisciplinary research team from Bolivia and the US, whose work examines gender-based violence through the combined lens of nursing, public health, and human rights. This research brings together clinicians, community-based program partners, and global collaborators to document structural factors, including legal frameworks, health system limitations, social inequities that shape survivors' access to safety, care, and justice. This work reflects the critical role of globally engaged nurse-led scholarship in identifying and addressing the structural basis that continues to affect survivors of gender-based violence. This, for me, is especially relevant and brings home the idea of the CSW, where as a clinician, I'm a trauma specialist focusing on these issues. I'm a nurse advocate and activist and a citizen of the world who cares very much about identifying and then intervening with these serious issues. I'm now pleased to introduce our moderator for this session, Dino Macari, the Executive Director of the ELA program. Thank you very much and enjoy this wonderful, important, and meaningful session.
Thank you so much, Holly, and thank you everybody for being here. So I will just start with this introduction. So good morning, and today's panel will be focused on gender-based violence, femicide, and the criminalization in Bolivia, and on the urgent need for structural change, as Holly said. Our discussion is informed by nursing, public health, and human rights perspectives, and it brings together people working across research, practice, and advocacy. We hope to use this conversation not only to describe the problem, but also to highlight why interdisciplinary and community-formed responses are essential to us. While we will not discuss specific narratives or case of assault, the perspectives involved in this panel focus on gender-based violence and related forms of trauma may be difficult of trigger. Please honor your own boundaries. Take breaks, steps away, or choose how and when to participate. Please reach out for support at any time. So we can go to the next slide just to see the agenda for today. So to begin with, I will briefly introduce the focus of the webinar, our team, and our panelists. I will then provide some context for today's discussion, including the broader setting in Bolivia, the policy landscape related to violence against girls and women, and some of the major barriers that continue to limit prevention, reporting, and response. After that, we will move into the panel discussion itself, and we will close with a short summary of key ideas and takeaways. And just to know that we have a designated segment for audience questions. So we are so excited to engage with attendees in this way. So while we will respond to questions at a specific time during the webinar, we welcome submission at any point leading up to this portion of the presentation on the Q&A section. So I will then present our team. This work is supported by an interdisciplinary team with expertise in human rights, research, public health, and community engaged work. Our collaboration reflects the central idea behind this webinar, which is that gender-based violence cannot be understood or addressed through only one discipline. It requires legal insight, health systems understanding, local knowledge, and sustained engagement with communities. We are very grateful for the opportunities to work together across these perspectives and to help create space for this dialogue. And then I'm going to present our panelists. So we are honored to be joined by this outstanding group. Our speakers bring experience from leadership, program implementation, clinical and community practice, research, and academic work. Together, they offer perspectives that connect institutional systems with lived realities on the ground. Their contributions are especially valuable because they help us move beyond the abstract discussion and towards a more practical understanding of what structural violence looks like, how it is sustained, and what meaningful change might require. Our panelists will introduce themselves in more detail in several minutes. I'm gonna just show the format of this conversation. So it's gonna be a bilingual session. We want the discussion to be accessible and welcoming across languages, and we also want to respect the voices of panelists speaking from different contexts. So the goal is not only to share information, but also to create a space for dialogue across perspective and locations. Because this topic is deeply connected to local realities, language access is an important part of making the conversation more inclusive and more grounded. So in the next slide, I will introduce the panel. This panel examines violence against girls and women and femicide in Bolivia through nursing, public health, and human rights perspectives. We are especially interested in how criminalization and structural inequities shape women's health and safety, and how health system, legal frameworks, and social conditions can both respond to violence and, in some cases, contribute to its persistence. Rather than treating violence as an isolated event, this panel approaches it as a structural issue on that one that is connected to institutions, access to care, social inequality, and the broader conditions in which women live. So about the geographic context about Bolivia, so the project and the research has taken place in the department of Santa Cruz, specifically around the city of Montero. So we are in the eastern part of Bolivia. Santa Cruz is one of the country's most important and populous regions, and Montero is a key city within the department. This geographic context matters because experiences of violence, access to services, and the institutional response are shaped by place. Regional differences, urban and peri-urban conditions, transportation, service availability, and local resources all influence what support is actually possible for women experiencing violence. So understanding where this work is situated help us better understand the practical realities behind policy and service delivery. Um, about the next slide, the policies on gender-based violence. Bolivia has an important legal and policy framework related to gender-based violence. The constitutional level, there is recognition of gender equality and of the right to live free from violence. Law number 348 is especially significant as it recognizes multiple forms of violence and establishes institutional mechanisms intended to protect women and coordinate response. The penal code also includes provisions related to femicide and sanctions for serious forms of violence. And in addition, complementary law address discriminations, trafficking, protection for children and adolescents. At the same time, one of the central points for today's discussion is that strong legal language on paper does not automatically translate into effective protection, access, or justice in practice. So following to the next one, I will discuss some barriers to violence reduction. So despite the policy framework I was talking about, major barriers continue to limit meaningful reduction of violence against girls and women in Bolivia. The difficulty is not simply the absence of laws, but the persistence of structural problems that affect prevention, reporting, and response. Among the most important barriers are limited awareness, the normalizations of violence, weak judicial accountability, and lack of resources. These barriers reinforce one another. For example, when violence is normalized, girls and women may be less likely to report it. And when institutions lack resources or accountability, reporting may not lead to safety or justice. This is why reducing violence requires more than legal recognition. It requires structural change across systems. So we will start now the panel discussion. So with all that context in mind, we now move into the panel discussion, and the purpose of this conversation, again, is to think together about what structural change really means in this context and how research, practice, and advocacy can contribute to that change. We hope to explore not only the challenges, but also the possibilities for stronger systems of support, greater accountability, and more effective interdisciplinary action. At the center of this discussion is a simple but important idea. Lasting progress requires more than awareness. It requires coordinated, sustained efforts that respond to the realities for that women and girls face in their daily lives. So with all that in mind, I will just call the panelists for a brief introduction of themselves and their topic. So Sarah, would you mind starting?
Of course. I always love to go first. Thank you, Dino. Um, Hello, everyone. Buenos dias a todos. My name is Sarah Hoffman. I'm an associate professor at the University of Minnesota School of Nursing. In my research role at the university, I study the intergenerational effects of trauma and gender-based violence prevention and response. On this team, I lead the research elements of our project. And then in addition to my university position, I also practice as a forensic nurse. I conduct acute forensic exams with survivors of sexual assault within 10 days of an assault, and exams with survivors of intimate partner violence within 5 days of an assault. And this position and this perspective has really informed what I bring to our team. I think a nursing perspective is critical because in many US healthcare settings, nurses often are the first point of contact for survivors of gender-based violence. This position allows nurses to recognize early indicators of abuse, provide trauma-informed care in both acute and long-term contexts, and document the health consequences of violence that might otherwise go unrecognized or unaddressed. Nurses are positioned to bridge healthcare systems, social services, and legal response while also advocating for survivor-centered medical interventions. As clinicians, the language that we use, particularly around consent, matters. When we speak to survivors, we are not speaking only as individuals, but as representatives of the systems and the institutions that we work within. For survivors, language is not simply words, it shapes how they experience and interpret the system's response to their experience. Careful, respectful communication can reinforce autonomy and dignity, while skepticism, pressuring, or victim blaming language can reproduce harm. And we've observed the power of language in our work in Bolivia. In settings where gender-based violence is normalized, like the communities where we work, the ways individuals think about consent varies. We are also working with a wide range from adolescence through early adulthood. Developmentally, there is variance in how we understand and respond to power in relationships. The relevance of language in our work has become prominent as participants in our studies were able to express verbally what had happened to them, many times for the first time, and to be told that they were believed and that what they were experiencing as a result of interpersonal violence was normal. As clinicians, researchers, and programmatic leaders and advocates, we need to be intentional about the language that we use and create spaces where young people can name their experiences, be believed, and begin to challenge the normalization of violence in their communities. Moving forward, our team thinks about prioritizing trauma-informed communication and developing developmentally appropriate education around consent so that adolescents and young adults have both the language and the support that they need to recognize and speak about violence. Ultimately, in my perspective, changing outcomes begins with changing language. Our responsibility is to foster environments where survivors can speak their experiences and know that they will be heard and know that they will be believed. Thank you, Dino.
Thank you so much, Sarah. Vanessa, would you mind going next?
Yes. Good morning. Buenos días a todos. My name is Vanessa Voller, and I'm a postdoctoral research associate with the Population and Health Systems Cooperative at the School of Nursing here at the University of Minnesota in Minneapolis, where I'm currently based. I am also a former Fulbright Fellow and Research Fellow with the Center for Global Health and Social Responsibility at the University of Minnesota, and my work very broadly has focused on adolescent pregnancy, experiences of sexual and physical gender-based violence, and then the rolling out of Bolivia's new sex education program back in 2023. I first came to know ETA projects in 2015 when I was an undergraduate student and I was studying abroad in Bolivia. And I've since had the immense privilege and opportunity to return several times, first in 2019, and then again, most recently over the past few years as part of my work at the University of Minnesota. And now on the team, I wear a couple different hats, but as I was preparing for today's talk, I was thinking of kind of my role of being the bridge sometimes between our Bolivia-based team and then our University of Minnesota-based team here as well. I was trained as a community-based participatory in participatory action research. And so oftentimes my role is helping to figure out how we take our sometimes overcomplicated methods from the university perspective and actually make it work in rural communities in Eastern Bolivia. Prior to my academic work, I served as a medical advocate for survivors of sexual assault here in the Twin Cities. I would accompany survivors throughout the forensic exam process at several emergency departments here in St. Paul and Minneapolis. And this experience profoundly shaped me and my approach to this research, and particularly centering survivor perspectives and ensuring that everything that we're doing is trauma informed. As Sarah mentioned, knowing that sometimes our research participants, this may be their first time and only time they've ever had a chance to disclose what happened to them. One of the core issues from my perspective, coming from very interdisciplinary field in public health and education, is really thinking about one of the long-term sequelae of sexual violence, which is unplanned adolescent pregnancy. Early on in my research, became particularly concerned about the number of very young adolescents that I was seeing in clinics showing up to receive contraceptive implants, and then also noticing that a lot of the young girls I was meeting out in communities were out of school, and many of them had one, two, three children. And so this, harps back to a point that Sarah made earlier, that in Bolivia, despite the really impressive human rights frameworks that they have, constitutional law that they have, there's a significant gap that exists between what's said in paper and then what actually happens out in rural communities, both with public health and preventing sexual violence, but then also supporting adolescent mothers. One thing that has particularly struck me about this team and the work that we do is the bridging together of research and then clinical service delivery. And the two things that I'm most proud of that we've done as a team is one, train community health workers and other healthcare staff in how to respond to disclosures of sexual violence in a trauma-informed way. And we're going to get a chance today to hear from one of them about that experience. And then number two, continuing to center and uplift ETA Project's amazing work on contraception access and contraceptive availability in rural communities. We know that for many girls, this form of contraception is just simply not available where they live. And oftentimes ETA Projects is the only lifeline that they have to making decisions about their reproductive health in the future. And then lastly, my key action or call to action for this group is particularly as a group of practitioners and also scholars is trying to do what we've started to do here with our small team, which is bridging together, again, academic research with actual service delivery to young people in rural communities. So thank you so much. I'm looking forward to our discussion today.
That's great. Thank you, Vanessa. And Natalia, you're next.
Thank you, Dino. Um, Hi, everyone. Buenos dias a todos y todas. My name is Natalia Otto. I'm an assistant professor of sociology at the University of Minnesota, and my work sits at the intersections of feminist sociology, critical criminology, and narrative methods. So I study mostly how the transnational war on drugs shapes the lives of women and girls in Latin America, with a particular focus on teenage girls incarcerated for drug trafficking and violent crimes in my home country of Brazil. I'm a new addition to this research team, and I'm really excited to begin collaborating. And most of what I'm going to be sharing today is actually from the perspective of my own work in Brazil and the sociological literature on gender violence and criminalization, which I think we can build in the future for discussions about Bolivia. Um, so. I'm really excited to join this research team and to contribute with to the qualitative dimension of the project, especially the collection and analysis of narratives from girl survivors of sexual assault. So in my work, I'm really interested in how multiple forms of violence in girls' lives, so gendered, interpersonal, state, and drug market related violence, for example, are mutually constituted and actually reinforce each other throughout their life trajectories. In Brazil, for example, I find that many girls that I interviewed turn to drug trafficking as a strategy to escape sexual and gender violence at home. And then they seek economic opportunities and the access to what I call the means of violence, so the ability to protect themselves through the use of firearms or peer protection from abusers at home. But once they go into these criminalized spaces, they encounter new forms of sexualized police violence and particular forms of intimate partner violence and sexual violence. They are produced in criminalized settings. So I'm really interested about the cycles of violence and how gender violence is transformed, but in a way, but constantly reproduced as girls attempt to navigate the spaces, right? Um, and because Brazil and Bolivia occupy different positions in the cocaine commodity chain, right? Bolivia is considered a producer country, Brazil a transit country. The forms of state repression and the criminalized organizations that emerge from these dynamics should look quite different. And I'm really excited to explore how this broader political economic dynamics shape girls' exposure then to sexual violence in Bolivia. And I think I'm excited to think together about the pathways, the vulnerabilities, and the forms of resistance that emerge for girls within these contexts. And because I have a short time, I would like to read a short passage from my work and introduce you to a participant from Brazil, from urban Brazil that illustrates the connection I'm describing here and that maybe can illuminate some of the connections that we might see when we think about girls in urban Bolivia. So I'm going to read from my field notes here. Um, it starts with a quote. Well, there's a family, mother, father, two kids. The mother makes minimum wage. The daughter gets pregnant. She has no money. She's too young. She can't get a job. So she'll quit school and she'll join a gang. Fernanda explained to me with the boredom of a 14-year-old girl describing the obvious. In a juvenile detention center in Brazil, she was telling me why girls like her turn to drug trafficking. The hours are good, she says. They can be with their babies. Fernanda's business savvy earned her a supervisory position at a drug sales point when she was just 13 years old. As a BOCA manager, she organized logistics, sales, transportation, and security in the hyper-violent cannabis cocaine market of Rio Grande do Sul, Brazil's southernmost state. But despite emphasizing profits in her explanation, her decision to join a gang was not just economic. During our conversation, I learned that before entering the drug trade, she was being abused by an older male relative at home. He ended up dying, she mentioned casually during the interview. I think it was divine retribution. I asked if she wanted to tell me how he died, and a glimpse of triumph crossed her eyes very briefly. And after a pause, she said, nonchalant as ever, I might have told the guys from the gang. The next day, his body was lying down the street. And yet, it was neither profit nor revenge that brought Fernanda to detention. She was incarcerated for an act of friendship. One of her friends owed money to a gang, and the friend was to be executed. To help him, she joined an armed robbery that went sideways. And while Fernanda was arrested, she watched the police kill her friend. So these are some of the connections between gender and sexual violence, drug trafficking violence, and state violence that I've seen in my work that I'm excited to explore with the research team in Bolivia. So thank you very much, and I'm very glad to be here and look forward to our collaboration.
Thank you, Natalia. And I think that this research is so important, so interesting. So thank you for being here, presenting it to us. So let's keep going with interests. So Penny, would you mind going then? You're muted.
There you go. Technology. Thank God we have it. And it can mute me at times. Buen dia a todos, and thank you all for the opportunity to be here on this panel. My name is Penny Nixon, and I'm the founder of ETA Projects, a nonprofit that has worked alongside communities in Bolivia for the last 23 years. Our mission really is simple but profound. It's to partner with Bolivian communities to address the public health challenges that most deeply affect their lives. And our work has primarily focused on improving access to clean water, safe sanitation, and healthcare needs. And these are all really fundamental conditions to dignity and health and opportunity that these communities deserve. But again and again, this work's brought us face to face with the powerful truth that we all know, that has been recorded over and over again, that women are at the center of community resilience and change. And over the years, our relationships in rural and peri-urban communities have grown into deep partnerships built on trust. And that trust has allowed women to invite us into conversations that are often hidden in silence. Conversations about gender-based violence, sexual assault, and the alarming rates of teen pregnancy in Bolivia, many of which are directly correlated with the realities of the sexual assault. We've been honored to be in that position. And again, I think as an NGO, being able to partner in research has really lent a new dynamic to our work in communities. And you'll hear from some of the community members later, but our community service providers. But anyway, I just wanted to say that. But I also want to recognize that for each woman, these are not easy conversations. They challenge the cultural norms to not talk about painful truths, and it really requires courage from the women who speak out, but even more important, for those communities to begin to listen to the women who speak out. And much of what research allows us to do is to approach those communities in a way that helps them to listen. And at ETA Projects, representing ETA Projects, we're honored to be a part of this panel and share this work that has emerged through our collaboration with the University of Minnesota School of Nursing. This partnership brings academic research together with NGO field experience, community leadership, and engagement through the local health system. And together we're learning how these different perspectives can inform stronger, more effective approaches to prevention and response. What we share today and what we're going to talk about there's no final answer here, but it's a growing part of a body of knowledge that is grounded in the voices and lived experiences of the communities themselves. So as you think about for later on, as you listen to this panel and all of you who are participating out there, as you think about your questions later, because we hope you ask lots of questions, because questions are what spur the next thought, the next idea. So as you think about your questions, I invite you to keep in mind one thing. Addressing gender-based violence requires action at every level of society. Prevention begins with children, continues through families and communities, and must reach the highest levels of institutions and policy. If we ignore any layer of this, we allow the cycle to continue. And so it's exciting to be here today and to work with everyone in this field and to be able to represent this nonprofit who gets to do this work. So thanks, Dino, and thanks, University of Minnesota.
Thank you so much, Penny, and thank you for this thorough presentation and description of ETA Project's work in Bolivia. And I am glad to introduce as well our colleagues from Bolivia. Well, they will introduce themselves, and that will be in Spanish. But we have two of our co-workers from Bolivia. One is a psychologist, and the other one is a healthcare service provider. And they have joined us to give their perspectives on this topic of gender-based violence. Entonces, voy a empezar a presentar ustedes, Carla y Edith. Quisiera que ustedes, por favor, vayan haciendo su presentación, su introducción brevemente, como hicieron los demás, y muchas gracias por estar aquí hoy con nosotros. Carla, quisiera que usted empiece, por favor. Gracias.
Muy buenos días. Good morning to everyone. I know a bit of English, but I manage more Spanish, so I'm going to talk in Spanish. Mi nombre es Carla Wills, soy psicóloga de profesión, tengo experiencia en el trabajo en el ámbito de lo que es el ámbito forense, clínico y comunitario. Actualmente trabajo en ETA Projects como coordinadora de un grupo de adolescentes femeninas que promueve el empoderamiento. Estos son programas psicoeducativos que abordan temas de salud mental, violencia, desarrollo personal y brindándole herramientas para su bienestar y empoderamiento. Muchos de estos temas son temas que no ven en casa y tampoco en el colegio. Aparte de ello, trabajo en el ámbito de salud como parte del gobierno autónomo municipal de Montero, en donde realizo valoraciones y terapias, donde comúnmente en estas atenciones hago la detección temprana de violencias y en muchos casos de niñas y de adolescentes, sobre todo violencias sexuales. Derivo estos casos para activar rutas de atención. También tengo experiencia trabajando en el sistema de protección de Bolivia, específicamente en la Defensoría de Niñez y Adolescencia y lo que son los SLIMs, trabajando directamente con estas víctimas de violencia sexual y violencias basadas en género, tentativas de feminicidio, maltrato infantil, realizando lo que son las valoraciones psicológicas que forman parte del proceso judicial para las sentencias de los agresores. He podido observar cómo la violencia basada en género deja profundas consecuencias en la salud mental de las mujeres y las niñas, muchas de las cuales permanecen invisibles o insuficientemente atendidas, afectando su desarrollo a lo largo de su vida y desencadenando otras patologías que incluso les genera dificultades en el ámbito educativo, las cuales en muchas oportunidades se mantienen en secreto hasta llegar a consulta. Al hablar de violencia sexual basada en género, es importante que el impacto no se limite al momento del hecho violento. Sus efectos en la salud mental pueden ser prolongadas y complejas, incluyendo ansiedad, depresión, estrés postraumático, sentimientos de culpa, miedo persistente y dificultades para reconstruir relaciones y proyectos de vida. Uno de los grandes desafíos que existe es una carga importante de la necesidad de la salud mental que permanece sin ser atendida en Bolivia y en específico Santa Cruz. Esto se debe en gran medida a factores estructurales que pueden ser el estigma social, el miedo a denunciar, la falta de servicios especializados en la salud mental, la revictimización institucional y las desigualdades económicas que limitan el acceso al apoyo psicológico en la comunidad. En muchos casos, las mujeres reciben atención inmediata por las consecuencias físicas de la violencia, pero el acompañamiento psicológico a largo plazo es insuficiente o inexistente. Mientras que en otros casos las mujeres hablan por primera vez a sus 50 años en una consulta psicológica porque lleguen por ataques de ansiedad en donde no hay una causa biológica. Y esto es una cadena que continúa con sus hijas y con sus familiares por el mismo hecho de que no hablan. En mi experiencia en la Defensoría de Niñez y Adolescencia, he acompañado casos de niñas y adolescentes que sobreviven a la violencia sexual. Muchas de ellas llegaban al sistema cuando el hecho ya había ocurrido tiempo atrás y cuando las consecuencias emocionales ya eran evidentes. Recuerdo un caso en especial que fue algo que me conmovió mucho, que no pasó, sucedió hace unos meses atrás, que me gustaría compartir, que fue con una de mis chicas, una de las chicas que forman parte del programa de las adolescentes que me llama para pedirme ayuda para ir al médico, ¿no? Ella tenía muchos dolores, le pregunto qué le estaba sucediendo y quebra en lágrimas y me comenta que fue violada hace unos meses, pero no le había comentado a nadie. Estaba con sangrados constantes, dolores persistentes en sus zonas genitales y no sabía dónde más recurrir. Cabe mencionar que esta chica luego me comenta que no es la primera vez que ha sido abusada sexualmente, que ha sufrido de múltiples violaciones desde que era muy pequeña y que nunca pudo comentar nada en casa por temor, por culpa, por miedo a que no le crean. Esto es algo muy lamentable porque el miedo se apoderó de ella. Junto con ella le acompaña este sentimiento de culpa. Se procedió a la ruta y denuncia del caso y asistió a Defensoría al llamado. Sin embargo, esa ayuda no fue suficiente porque al llevarla al hospital, en donde debería haber un sistema, un protocolo de actuar, que fue lo que realizó, revictimización, preguntas, tildos de mentirosa, y cuando pasó por el procedimiento médico para que se le haga una ecografía transvaginal, no se le explicó lo que estaba sucediendo. Una adolescente de 15 años que viene a haber sufrido una violación en donde la drogaron y no tuvo conciencia, fue algo muy lamentable porque sentía mucho temor y nadie le explicó el procedimiento por el cual iba a pasar. En estos contextos, el apoyo psicológico inmediato era fundamental para estabilizar emocionalmente a la víctima, pero también para ayudarla a comprender que la responsabilidad nunca es suya. Este tipo de intervenciones tempranas puede marcar una gran diferencia en la forma en que la víctima procesa la experiencia y su proceso de recuperación, pero es algo que lamentablemente no se logra. En todo este proceso que estuvo, no asistió la psicóloga de Defensoría, yo les realicé el acompañamiento. Sin embargo, la abogada que sí estaba para acompañarla no pudo hacer nada tampoco. Fue algo que ella se mantuvo a un lado mientras que los médicos decidían dónde llevarla, la buscaban y les seguían realizando preguntas como si fuesen policías. Una de las principales lecciones que he aprendido desde la práctica es que la atención a la violencia de género no puede limitarse a la respuesta legal o médica inmediata. Es fundamental fortalecer una respuesta integral que incluya atención psicológica informada por trauma y accesible a largo plazo, en donde sobre todo el acompañamiento físico y emocional puede marcar una diferencia. Esto implica fortalecer las articulaciones entre el sistema de salud y el sistema de justicia y los servicios sociales. También requiere de mayor inversión en la salud mental, capacitación al personal sanitario para detectar señales de violencia y políticas públicas que prioricen recuperación integral de las sobrevivientes y sobre todo el trato hacia las víctimas para evitar la revictimización. Capacitar en cuáles son sus funciones como el ámbito de salud, o como el ámbito de la institución legal. Si queremos romper los ciclos de violencia, debemos garantizar no solo la protección inmediata, sino también procesos reales de recuperación y reparación emocional y acompañamiento.
Muchas gracias, Carla. Thank you so much, Carla. I think that your insights are so important, and also they speak a lot on the real situation that girls and women face in Bolivia daily. When it comes to seek service or even just advice from a healthcare provider, but also by the system, they should take care of them. Entonces, muchas gracias. Eh, Vamos a seguir con Edith, por favor.
¿Cómo están? Buenos días. Me presento, soy Edith Camacho. Mi trabajo en ETA Project nace desde la urgencia de transformar el sistema de salud, que a menudo llega tarde a las necesidades de salud integral y seguridad de las mujeres. Trabajo como enfermera más de 10 años en el municipio de Montero, Santa Cruz, evaluando indicadores de salud, ¿no? y salud comunitaria. También evalúo y trabajo con pacientes en programas de prevención en el VIH y diabetes. Y dentro de mi experiencia en este proyecto, ¿no? me ha tocado la gran labor de poder captar a este tipo de pacientes con violencia en manera de crear un puente que las derive o que les ayude a tener ayuda psicológica, ¿no? Eh, Desde mi experiencia en la salud comunitaria, trabajando principalmente con familias de escasos recursos, vemos que la violencia de género no aparece como un hecho aislado, sino como una realidad que refleja las desigualdades estructurales. Aunque en Bolivia contamos con avances como la Ley 348, en la práctica vemos que las mujeres siguen enfrentando muchas barreras para acceder a la protección y a la atención afectiva, ya sea por falta de recursos, las debilidades institucionales y en algunos casos el proceso de revictimización, como mencionaba la doctora, que pueden que esto dificulta que ellas puedan salir de este ciclo de violencia. Dentro de más allá en mi rol de hacer llenar un formulario, se podría decir, o hacer parecer que esto fuese un interrogatorio, mi labor fue centrada en hacer sentir a la paciente con confianza y segura de los datos que ella estaba transmitiendo. Era crear el espacio seguro donde la paciente se sienta escuchada y pueda sentir que dentro de mi persona tenía la confianza y el soporte para ella no seguir cargando con ese peso y esa culpa, ¿no? Dentro de todo el trabajo que realicé en el proyecto, también quisiera compartir algunos casos, algunas experiencias que me marcaron, no mucho porque es primera vez que yo trabajo en este tipo de proyectos y es lamentable, ¿no? ver que aún sigue sucediendo en Bolivia cuando ya tenemos medios de acceso a la información, cuando deberíamos sensibilizar más a la población respecto a todo lo que conlleva, ¿no? el tema de violencia de género y encontrar en comunidades aún este tipo de casos, pues me lleva a la reflexión de que estamos fallando como sociedad. Recuerdo el caso de una paciente actualmente de 20 años con 3 niños. Ella fue víctima de violación a sus 5 años y me llamó más la atención porque su agresor, un miembro de su propia familia, quien después de realizar el hecho dejó a la niña abandonada en una calle a oscuras para que ella fuera encontrada así, como si se hubiese perdido, ¿no? Se hizo parecer la situación. Entonces me llamó la atención bastante ese caso porque, o sea, ¿cómo puede ser que dentro de tu familia exista todavía este tipo de casos que debería ser el núcleo de protección de tu familia y que te deje este tipo de secuelas, ¿no? Entonces, creo yo que en Bolivia deberíamos, con este proyecto, avanzar en una respuesta reactiva, de una respuesta reactiva a una respuesta preventiva, coordinada y centrada en las mujeres. Para ello es fundamental fortalecer la articulación entre el sistema de salud, la policía y la justicia, incluyendo mecanismos efectivos de intercambio de información que permitan actuar de manera oportuna para evitar que las mujeres sigan desprotegidas. Muchas gracias.
Muchas gracias, Edith. Creo que su labor y junto con la de Carla son labores extremadamente importantes, pero también, o sea, muy también difíciles cuando se ven estos casos, sobre todo si afectadas son adolescentes, niñas, y los casos son dentro de del núcleo familiar, obviamente, ¿no? Entonces, vamos a pasar ahora a la pregunta para ustedes. So, thank you all. Thank you to all our panelists for their insights and for, giving us to share their expertise with us on this matter. I just wanted also to remind participants that they can ask questions in the Q&A chat, and we will address them later on during the panel. So you can type them at any time. But now I want to ask some questions to each one of the panelists to dive deeper on gender-based violence in Bolivia. Natalia, if you don't mind, I would like to start with you. So my question for you is this: how do existing legal and criminalization frameworks shape survivors' access to healthcare, protection, and justice?
Thank you so much, Dino. So I'll talk briefly about women's access to justice in Latin America. And following what you said, in the introduction, what is really striking about Latin America is that the problem is not the lack of laws, right? In fact, Latin American countries have some of the most progressive, gender-responsive, feminist-forward legislation in the world. Much of it emerged during what we call the pink tide governments, so the center-left government from the early 2000s onwards, right? We have a very strong tradition of judicial activism and very strong feminist social movements. But at the same time, the region has the highest rates of violence against women in the world. In the sociology of law, we call this a gap between the law on the books and the law in action. So the written law and the law that is actually enacted. And in Latin America, in terms of gender legislation, this gap is enormous, right? And this is a crucial theme in the literature on sociology of law, gender-based violence, and Latin American studies. And there are some themes that help us to explain why, and I think we can think with these themes in the context of Bolivia. So the first one is something that sociologist Cecilia Menjivar and Lady Diosa Jimenez called familism, which is the idea that women and the family are the same, and that the interests of women are the interests of the family. This makes it so the gender-based violence is often routed through or processed through, for example, family courts rather than criminal courts, where the goal becomes preserving the family, pacifying the family, and preventing family dissolution rather than ensuring women's safety and justice. So we could think about how I don't know the answer to this, but we could think about how or whether this notion of familism plays out in the context of sexual violence against girls, which is often, as our panelists said, a question of family, right? A question of violence in the family. A second really important theme in this literature about women's access to justice are the legacies of authoritarianism and civil war in Latin America, right? A lot of literature in places like Guatemala and Peru talk about how the history of these conflicts towards the later end of the 20th century helps normalize violence in the region, and specifically violence against women, and tragically sexual violence against women, as they have been used as weapons of war in this context. And in countries like Brazil, for example, we also have democratic security institutions that remain militarized, following military logics, of authoritarian policing, including following the rationales of torture and forms of sexual torture. So the question of access to justice in Latin America is very complex, and we are dealing with a contemporary democratic society, which is in a way very progressive, and where communities and feminist movements have a lot of strength. But at the same time, we're dealing also with historical legacies of our own political economy and the gender ideologies of the region, right? And those dynamics vary by country, but they offer, I think, important lenses for us to think about Bolivia.
Thank you so much, Natalia. I think your perspective is so valuable, and yeah, it's a complex situation in all Latin America. And yes, I really like the fact that put it into historic perspective and the cultural factors that play a role into the violent situation of women and girls in Latin America and also in Bolivia, of course. So following to this topic, I would like to ask Carla actually. Um, Carla, obviamente le voy a preguntar en español, ¿en qué manera el sistema de salud en Bolivia está respondiendo a la violencia de género y dónde persisten todavía barreras estructurales?
Gracias, Dino. Si bien los sistemas de salud cumplen un rol muy importante como uno de los primeros puntos de contacto para muchas víctimas de violencia de género, en especial las adolescentes que vienen con embarazos, ¿no? En algunos de los casos, el personal sanitario logra identificar señales de violencia y brindar la atención médica inmediata y activar mecanismos de derivación hacia instituciones de protección o justicia, porque ya hay una ruta de atención establecida. Sin embargo, todavía existen muchas barreras estructurales. Una de ellas es la falta de capacitación especializada del personal de salud para detectar indicadores de violencia, especialmente cuando las víctimas no lo verbalizan directamente, que suele suceder mucho con las adolescentes. Muchas mujeres acuden a consulta por síntomas físicos o emocionales, pero la violencia subyacente no siempre es identificada, que comúnmente se ve con la violencia verbal y también sexual. Otra barrera es la sobrecarga laboral y la falta de recursos humanos en instituciones como lo que son las defensorías LIMS, al igual que también en los centros de salud. Es una población, son instituciones que están con constante carga laboral que muchas veces no se toma en cuenta su salud mental de quienes están ofreciendo este servicio de atender, ¿ya? Esto afecta negativamente en la víctima y en otras oportunidades las opiniones personales del equipo multidisciplinario también afecta el curso de la denuncia. Los adolescentes y las víctimas de violencia son personas que están en oportunidades muy influenciables, entonces la opinión personal que tenga la persona o aquel profesional que la está atendiendo va a influir en el curso de cómo va a llevar a cabo su proceso. En el año 2025 se atendió un total de 1.083 denuncias formalizadas de casos de violencia en el municipio de Montero, más de lo que se le atendió en el año 2024, en donde existen para únicamente 2 equipos multidisciplinarios que atienden 24/7, está también el desgaste emocional y físico en estas instituciones que no se toma en cuenta en oportunidades. Otra barrera importante es la limitada disponibilidad de servicios de salud mental dentro del sistema público. Incluso cuando la violencia es detectada, muchas veces no existen suficientes profesionales o programas que puedan ofrecer acompañamiento psicológico continuo. Si bien la Defensoría tendría que realizar este seguimiento y darle las terapias continuas, es algo que no se realiza, dejando a la víctima en un estado emocional vulnerable que le generan secuelas a largo plazo. También persisten los factores sociales y culturales que dificultan la búsqueda de ayuda, como el miedo a denunciar, la dependencia económica, la normalización de la violencia, que es algo muy común por la cultura y el contexto, y la desconfianza hacia las instituciones por experiencias pasadas. Por eso es fundamental avanzar hacia modelos de atención en salud informadas por trauma, fortalecer la formación del personal sanitario y promover una coordinación más efectiva entre el sistema de salud y el sistema judicial y los servicios de protección social. Solo a través de una respuesta intersectorial podríamos abordar de manera más efectiva la violencia de género y sus profundas consecuencias en la salud mental de las mujeres. Gracias.
Muchas gracias, Carla. Sí, efectivamente, el tema de multifacético, ¿no? El tema de la falta de recursos que sean humanos, que sean materiales, que también de financiero hace que también no pueda haber los servicios suficientes, ¿no? Para hacer seguimiento a los casos, pero también para atender de emergencia, ¿no? Los casos de la forma adecuada, ¿no? Para estas mujeres, para estas niñas y para esas adolescentes. Así que eh, eh, hay que seguir trabajando justamente en ello con más ganas y también, pues, sobre todo, pedir a las autoridades, ¿no? A quien toma decisiones, que hagan algo, ¿no? Que vean cuál es la situación y que hagan algo al respecto para dar un servicio mucho mejor, ¿no? Para las víctimas de abuso y de violencia. So, I'm gonna just interrupt the questions now because I think that we have a technical problem. Mary, I think that you are muted. Um, I don't know if audience was able to uh, to hear you. So, but we will have a script about the answer from Carla. So we will send that to our participants later on. So I mean, these things happen, so no problem. So it's okay. We will keep going with our Bolivian partners. Edith, quería seguir con usted en realidad con una, digamos, pregunta sobre las prácticas o sobre una pregunta sobre práctica de la comunidad, digamos, la perspectiva de la comunidad donde usted trabaja y viene trabajando desde hace 10 años, ¿no? En Montero. Mi pregunta es, ¿qué rol tienen las enfermeras, trabajadores comunitarios de salud, sobre todo, los que están más a contacto con las personas, digamos, ¿no? A diario? Eh, para los sobrevivientes de violencia y los cuidados posteriores a ellos.
Eh, bueno, como trabajadoras de salud comunitaria, acá en Bolivia la función más que todo es conectar con la comunidad al sistema de salud. Dado que vivimos y trabajamos en la misma zona, en las comunidades, entendemos el idioma, las culturas, eh, comprendemos las experiencias cotidianas de las personas a las que servimos, y esto es lo que ayuda a generar un poco más de confianza, ¿no? Entre el personal de salud y el paciente. Cuando las sobrevivientes de violencia o trauma necesitan ayuda, esa confianza es fundamental, ya que así podemos conectarlas con ayuda del profesional en salud mental. Y los promotores en salud también suelen dar la información y el apoyo emocional a las personas que no comprenden el sistema que hay disponible para ellas, ¿no? Entonces, dentro de todo lo que es la salud integral, tratamos de ayudarlas concretamente con el tipo que ellos necesitan de atención. Y en el hecho de la violencia, cuando se detecta algún tipo, también generamos esa confianza que hay para que ellas se animen y hagan la denuncia correspondiente, ya que dentro de las comunidades como que tienen el trauma, se podría decir, de no denunciar por miedo, por revictimización, como mencionaba la doctora también, y porque aún se cree de que las mujeres no tenemos el mismo derecho, ¿no? Que un varón. Ellas tienen esa mentalidad todavía. Gracias.
Muchas gracias, Edith. La verdad es que este acompañamiento que ustedes como trabajadoras comunitarias, como enfermeras hacen a las mujeres es imprescindible, ¿no? Dado que el tema de los estigmas y prejuicios todavía impregna, ¿no? Su forma de actuar y su forma de pensar sobre todo, ¿no? Entonces, hasta el tema de denunciar es un paso muy grande y a veces demasiado grande para algunas personas. Así que, bueno, gracias por todo el trabajo que hacen. Okay, so from community-based perspective and also from practice-based, I would like to ask Penny this time. So, from your perspective, how can a partnership between NGOs, researchers, local communities, and the health system lead to positive change for girls and women in Bolivia? And also, what about prevention?
Thanks, Dino. Well, as we've just heard from Natalia, Carla, and Edith, even with strong laws that exist, they're only effective if the structural systems support them, which Carla has just talked about. There's not the money available. There's not the system in place to really respond. So those systems for enforcement, reporting, and the systems that should be accessible to victims just aren't in place, even though the law says they should be. So, as we know, in Bolivia, those systems are still developing, and many girls and women remain without the protection and support they need. So the question becomes, what does meaningful forward movement look like right now from the work we're doing in this moment? And I think this is one of the most promising paths forward is this collaboration between NGO, researcher, local community, and health systems. Long-standing NGOs play a critical role because they bring history, trust, and relationships within the communities they serve. That trust opens doors for researchers to ask the questions that might otherwise be too sensitive or culturally difficult to approach. Without that established presence, many of these conversations would simply just not happen. At the same time, local health professionals and community members add another essential layer. The nurses, doctors, educators, parents, psychologists are willing to learn about these issues and engage in the dialogue together. They become the true agents of change within their own communities. And you can see that in your conversations with Carla and Edith. They're the ones who will continue the work long after the research project ends. But the research itself plays a powerful role because it provides local evidence. And what do I mean by local evidence? Well, everyone in Bolivia knows and understands that sexual violence is a national problem. But for people in the community, national statistics can feel distant and overwhelming. The issues often seem too large or too abstract for communities to act on. But when parents sit in a meeting or in a fair with their local nurse, with Edith, for example, or a doctor or a psychologist like Carla, and they hear the research conducted through clinics in their own region that shows that 77% of girls worry about sexual or physical violence, and that 37% or more will experience it. The conversations begin to change. When those same communities can see the connection to unplanned pregnancies that end girls' education and limit their futures, the issues kind of become immediate and very personal within those communities. It's really hard to change national ideas, national cultural issues, but on a more community level, which we've seen within the context of this project and other projects that we work on, we do see changes. We see differences. We see when implants or contraceptives or girl-forward contraceptives are available to girls, we see a decrease in unplanned pregnancies. We can document that change with the help of researchers. So we hope this kind of local data transforms awareness into action. It allows parents, educators, health professionals to recognize that change must begin where they live. And for an NGO like us, after more than 2 decades working in this region, I can tell you this research has provided some of the leverage we've long needed to open doors for deeper conversations and trainings with medical staff and educators. The publications resulting from the University of Minnesota's work have helped create the credibility and momentum necessary to take the next steps. For example, we can have more open discussions about providing long-acting contraceptives for girls and young women. Contraception is not the solution to violence, but it can offer protection that can end a protection that against one of the more devastating consequences of sexual violence, an unwanted pregnancy that then would end the girl's education, force her into maybe an early marriage with an abuser, and even lead to life-threatening pregnancy complications. So while we cannot yet predict the long-term outcomes of this collaboration that we're all working in, we're already seeing some progress. The partnership between researcher, NGO, local health systems, and communities has opened conversations that were once closed. It's created a shared understanding of the problem and provided the evidence needed to support some advocacy. In the end, research alone doesn't create change, but it does give the other advocates the foundation on which change can begin to be built. It helps us all break those silences. So again, I think the value of this collaboration, I don't know. I don't even know if we know the value yet, but we are certainly very hopeful and very appreciative of the ability and the opportunity to work together and try to create some change.
Thank you so much, Penny. And keeping, talking about this cross-sector collaboration, I would like to ask one last question to Vanessa, which is, where do you see critical gaps that require further coordination or structural change? What concrete actions or policy shifts are most needed to strengthen survivor support and prevention efforts in Bolivia?
Well, thank you so much, Dino, for the question. I'll keep it brief because I know we want to make sure to get to guest questions as well. And I'm actually going to bring it back to in 2023, Bolivia passed a very progressive new comprehensive sex education policy. And a core aim of that sex education policy was number one, prevention of gender-based violence among adolescents and young adults, but then two, also to reduce rates of adolescent pregnancy. Unfortunately, through my dissertation research and conversations I've had with many of our colleagues at ETA projects, that curriculum, again, this overarching theme, while on paper it's really nice, in practice it's not happening. So I think if I were to kind of end with one key policy piece today, it would be making sure that all schools across Bolivia are properly equipped to teach that amazing curriculum that they've put together, make sure that parents are aware of it, make sure that health workers and other health staff are aware of it. And then secondly, just to underscore what Carla and Edith said as well, I think unique to our project that we've done over the last few years is we trained local health workers, as I mentioned earlier, on trauma-informed responses to disclosures of sexual violence. That's not common in Bolivia, having that kind of training for health workers. And so making sure that that training is also available to health workers across the country. So if there is a disclosure of sexual violence, that any health worker would be able to respond appropriately and get that survivor in the line to receive what they have the right to receive. So thank you for that question, Dino.
Thank you so much, Vanessa, for your insights and for everybody's. Now I think that we are ready to for the Q&A portion of this panel. So to all participants, if you'd like to type your questions and we will be happy to answer them. It can be a general question, or you can address a question to a specific panelist. So just go ahead. We'll have probably 5 minutes, 7 minutes to do that before going to the final part of this webinar. Entonces, si hay preguntas que quieren hacer también en español, no hay problema, la pueden también escribir en español porque la vamos a traducir al inglés a través de nuestro intérprete, de nuestras funciones, y también la vamos a contestar en español. So we talked about a lot of topics such as, the law, the legal systems in Bolivia, but also different legal systems in Latin America, the situation that women and girls in Bolivia, but also in general in the region face when they are sexually abused and they seek help, and the challenges and limitation of the local healthcare and judicial systems. They're dealing with prejudice, with bias, and other stigmas. So it's such a complex scenario. Um,
Sorry, Dino, I think
yes.
Yolanda has their hand up in the attendees.
Oh, I cannot see actually. Yes. Yolanda, yes.
Yes, I just wanted to ask, is there any plan to engage legal or police?
Is that a question for at the projects?
Sure.
Yeah. So thanks for the question first. So we have planned to create another program where we are working more closely with policymakers and with decision makers. So our plan is to create this kind of round table where we are together with, healthcare staff, with the president of rural communities or neighborhoods, but also teachers, parents committees. In Bolivia, every school has a parents committee, which holds a lot of power on, what activities can be done in the school or what topics can be taught in the school, and municipal authorities. So with the aim of starting a conversation around sexual and reproductive health, um, rights, especially for young people, for teenagers and girls, and then share with them, especially this last data and outcomes that we have gathered thanks to the University of Minnesota and the research. So what we want to do is share with them, let them see what the real situation of the local reality is, and have them make decision according to that data, to that outcomes, because we have the data on hand now. So we wanted them to think about it and to be accountable for the situation that girls and women face there. So yes, probably we will start working more with, local authorities, policymakers, and people working in the police. Thanks, Yolanda. Anybody else? Before we jump into the closing portion? Okay, then. Sarah, I think that we can start with an overview of the research, if you don't mind. What do you think?
Yeah, that sounds great. Tom, do you mind advancing the slides, please? Thank you so much. So yeah, as we move to close the webinar, we've had a couple of panel members talk about the role of research in this project and in this team, and so we thought it would be important to share some of our findings to date with people in the webinar. So we have a few slides that highlight some of our key findings, and then we'll move into a summary and close. So this slide provides a brief overview of the study that informed part of today's discussion. Our research used a cross-sectional design to examine violence exposure, disclosure, and sexual and reproductive health among adolescents and emerging adult participants between the ages of 12 and 33. Can you advance the slide, please? So each of these slides have a duplicate English Spanish language component. So we'll make sure that we get equal time with both slides through this final leg of the presentation. You can actually go back one. Thank you. Yes, perfect. Okay. So these are the results of our preliminary analysis. We included in this analysis is 200 participants, and our final sample will include closer to 300 participants. We're in the final phases of data collection now. The sample characteristics that we display on this slide help to situate the population represented in the data and remind us that the findings reflect the experiences of young people who are navigating violence, health, and social systems during important stages of adolescence and early adulthood. Next slide, please. This slide highlights several important sexual and reproductive health findings. First, 94% of participants reported that they were currently or ever had been sexually active. At the same time, access to sexual and reproductive health care and contraception was not consistent, especially among our younger participants. Can you advance the slide, please? So while young people are sexually active, access to supportive and preventive health services remains imbalanced. This gap is important because it places young people at greater risk and limits their ability to make informed and safe decisions about their health. And this was reflected, I think, in the panel responses as well. Next slide, please. This slide shows that concern about violence was high across all age groups in our study. Violence was consistently recognized as a serious issue. Around 77% of participants rated both sexual violence and physical violence as at least somewhat concerning or significantly concerning. And there were no differences across age groups. Advance the slide, please. And we think that this tells us something important. That concern about violence is not isolated to one particular age group, but rather it is broadly shared, suggesting that violence is understood as a serious and widespread issue across the population represented in the study. In other words, awareness of the problem exists, but as we'll see, awareness alone does not guarantee safety, disclosure, or access to support. Next slide, please. So this slide moves from concern about violence to direct experiences of violence and patterns of response. 37% of participants in our study were impacted by sexual violence, and among those, 70% were personally victimized. The mean age of onset for sexual violence was 11.4 years, which is especially striking because it indicates that exposure often begins very early in life, where interventions begin later. Next slide, please. 37% were also impacted by physical violence, and among those, 67% were personally victimized. The mean age of onset for physical violence was 16.9 years. Another really important finding on this slide is the very low uptake of formal support. So in all of these individuals in the study that reported violence exposure, only 17% of sexual assault survivors and 22% of physical assault providers accessed legal advocacy or healthcare services. So this, further suggests that there is a major gap between the experience of violence and meaningful access to institutional support. Next slide, please. And then finally, this slide helps us to understand why those gaps exist. The qualitative data that we collected revealed both interpersonal and systemic barriers that prevent survivors from reporting violence or receiving appropriate care. Shame and fear were major reasons for non-disclosure, especially in the context of intimate partner violence. Another barrier was not being believed. Next slide, please. Some participants described disclosing to family members, often mothers, and not being taken seriously. Others minimized what had happened to them, especially when the assault did not fit a narrow or commonly recognized definition of violence. There were also systemic gaps, including cases in which people were denied formal support because the violence did not meet certain institutional criteria. The quote on this slide reflects the lasting impact of these experiences, while also showing that insights and strengths of survivors were very present in the voice that was shared with us. These results remind us that the problem is not only violence itself, but also the conditions that make disclosure unsafe and support inaccessible. Next slide, please. So as we begin to close the webinar today, we want to thank all of our panelists and all of the participants for engaging in this important conversation. As we close, we wanted to underscore a few key points. Gender-based violence is not only a human rights issue, it is an urgent public health crisis. Its impacts are far-reaching, affecting physical, mental, and reproductive health, and extending beyond individual survivors to families, communities, and entire systems of care. We've also heard clearly that violence does not occur in a vacuum. Structural factors, legal frameworks, criminalization, social inequities, and gaps in institutional accountability shape both the risk of violence and the pathways that are available for protection and healing. Addressing gender-based violence requires confronting these broader systems and not just the isolated incidents. Finally, health systems are not neutral. They play a dual role. When grounded in trauma-informed, survivor-centered approaches, they can be powerful sites of healing and support. But when care is fragmented, stigmatized, or inaccessible, they can unintentionally reinforce the exact barriers that survivors are working to overcome. So our collective challenge and our responsibility is to ensure that the systems that we build and work within consistently move toward equity, toward accountability, and toward compassionate care. Thank you all for being part of that vision and effort. Next slide, please. And I'm going to turn it back over to Dino. But before I do, I just wanted to say a quick thank you to Dr. Holly Shaw, Kalaine Haas, Steve Rudolph, Tom Steffes, the Densford Center, and the School of Nursing for all of this support in shaping and making this webinar even possible. So Dino, back over to you.
Thank you, Sarah, and thank you all for the presentation, the great presentation you've given to all participants, and for your expertise and your time for this panel. So we've come to the end of this webinar. And as we close, I would like to emphasize that addressing violence against women and girls in Bolivia requires more than strong laws or isolated interventions. It calls for a sustained, coordinated action across health systems, legal institutions, and communities, grounded in accountability, equity, and lived realities. And by approaching violence as a structural issue, we open the door to more meaningful and lasting change. And it's a change that not only responds to harm, but actively works to prevent it. So thank you for being part of this important conversation. Muchísimas gracias a todas y a todos por estar aquí hoy con nosotros, con esta Projects y la Universidad de Minnesota. Thank you to Happy Show again for giving us the privilege to create this panel, and for your commitment to advancing safer, more just conditions for women and girls. Thank you so much.